Greetings and hope you're having a good day. Today we are discussing craniopharyngioma, an important brain tumor that, although histologically benign, can cause problems because of where it grows. Craniopharyngioma arises from the embryologic remnants of the Rathke's pouch and is usually found in the sellar or suprasellar region, close to the pituitary gland, the optic nerves, the hypothalamus, and the third ventricle. This means that even a non-cancerous tumor can significantly affect vision, hormones, growth, weight regulation, as well as other brain functions. For the general public, it is useful to know that craniopharyngioma often presents slowly. A child may have poor growth, delayed puberty, excessive weight gain, headaches, vomiting, or declining school performance. An adult may develop headaches, visual loss, fatigue, reduced libido, menstrual disturbance, or other hormonal imbalances. Because symptoms progress gradually, diagnosis is sometimes delayed. For undergraduate medical students, remember that raised intracranial pressure, endocrine dysfunction, and visual symptoms form the classic triad of presentation. There are two major subtypes. The first is adamantinomatous craniopharyngioma, more common in children, often cystic and calcified. The second is papillary craniopharyngioma, more common in adults, usually more solid, and often linked to BRAF mutations. This distinction matters because it can influence treatment strategies and future targeted therapies. Diagnosis mainly relies on imaging. MRI is the best investigation for defining the tumor, its cystic or solid components, and its relationship to the optic chiasm, pituitary stalk, and hypothalamus as said earlier. A CT scan is especially helpful for detecting calcifications, which is common in adamantinomatous lesions. Endocrine blood vessels and formal visual assessment are also essential parts of the workup. Management requires a multidisciplinary team involving neurosurgeons, endocrinologists, ophthalmologists, radiologists, oncologists, and rehabilitation specialists. Surgery is often the first step, either to decompress pressure, drain a cyst, obtain tissue diagnosis, or remove tumor safely. However, modern treatment has moved away from aggressive surgery at all costs. Preserving hypothalamic and visual function is often more important than radical resection. Residual tumor may be treated with radiotherapy, especially focused modern techniques such as IMRT or proton therapy where available. For postgraduates, remember that long-term outcomes are heavily shaped not just by tumor control, but by survivorship issues. Many patients require lifelong hormonal replacement. Some develop diabetes insipidus, obesity from hypothalamic injury, cognitive difficulty, sleep disturbances, or visual disability. Therefore, follow-up must be long-term and holistic. So, in conclusion, craniopharyngioma is a benign tumor with potentially life-threatening consequences because of its critical location. Early recognition, careful imaging, balanced surgery, and multidisciplinary long-term care are keys to achieving the best outcomes. Thank you for listening and have a blessed day.